Now I would like to introduce our speaker, Dr. Rachel Fabi, Assistant Professor in the Center for Bioethics and Humanities at SUNY Upstate Medical University. Dr. Fabi, you may now have the floor.
Thanks, Isabel. Hi, everyone. So there's a link on the screen for the poll everywhere. I was hoping that I could make this session super interactive and have breakout groups, but we were not technologically capable with this big of a conference to make that happen. So instead, we're doing a little bit of poll everywhere throughout the talk. And I'm going to switch now to that screen. Hopefully people will put in some answers. Let's see. Oh, there it goes.
Got it.
Oh, this is really exciting. So, all right, while this is loading up, while people are putting in their answers about what health advocacy means to you, I'm just going to talk a little bit about today's session. So, as Isabel mentioned, I'm Dr. Rachel Fabi. I'm an assistant professor in the Center for Bioethics and Humanities here at SUNY Upstate. And my work is in the immigrant health space. I also teach a course on health advocacy for second-year medical students. So today's talk kind of marries those two interests of mine, advocacy and immigrant health, and specifically policies that affect immigrant health. And we're going to talk about three of my heroes who do advocacy work in the immigrant health space. And so I just want to take a quick look at this word cloud. So we see in the middle healthcare. That makes sense. Healthcare is obviously huge to people's health. But I also love how giant the word work is. Advocacy is not easy. Advocacy is really actually a challenge. And you have to really care about the work that you're doing to do health advocacy well. And so that's wonderful. Voice, giving voice not just to yourself as a healthcare provider or someone who works in the health space, but to the community that you serve. That's a huge part of advocacy as well. And we're going to see a lot of these ideas represented in this word cloud in the stories that I'm going to tell today. So I'm going to navigate back to my PowerPoint. And we're gonna take a look at these three stories. But before we actually get to these three stories, we're gonna talk a little bit about sort of a formal definition of health advocacy. So we had a whole bunch of great ideas generated in that word cloud. But I'm gonna give you a definition adapted from the American Medical Association. And then I'm gonna talk about immigrant health and specifically the policies that impact what public health insurance immigrants are eligible for in the United States. And then I'm going to dive into these stories, which is really the meat of today's talk, giving you three examples of really incredible women who work in immigrant health advocacy. And then at the very end, we're going to have a little bit of time for you to reflect on these three stories and which of these avenues of advocacy and types of advocacy make sense for you. And so at the end, I'll have a couple of suggestions for things that you can do in the health advocacy space for immigrants. That you can act on or not, but I'd be really tickled if you did. So starting with this definition of health advocacy. And again, this comes from the American Medical Association. This was originally a definition of physician advocacy, but as we all know, physicians are not the only ones who can be advocates. They're not the only ones who see patients. So I've sort of broadened this to include anyone who works in a health space, any clinician or other stakeholder. So physician, nurse, PA, social worker, public health practitioner, action by those physicians or by those people to promote those social, economic, educational, and political changes that ameliorate the suffering and threats to human health and well-being. And so before I go on to the end of the definition, I just want to spend a little bit of time with this. Often when we think of health, we think about your immediate physical health. But as I'm sure all of you know, because you chose to attend a conference on health justice, it's about so much more than just healthcare and the immediate choices of an individual. There are social, economic, educational, and political factors that can impact a person's health. And so any work to address those factors counts as advocacy. And the last part of this definition is that these threats that affect human health and well-being are often identified through a clinician or other health stakeholders' professional work or expertise. So physicians, nurses, all of those stakeholders that I mentioned earlier are particularly well situated to see the effects of these social, economic, educational threats on human health. And so by identifying those threats in their work, they're sort of uniquely positioned to address them. And this is just a working definition. It's not the only one. but it's one that I use in my work and my teaching when I think about health advocacy. So many of you are probably familiar with this, but just in case you're not, this is the social ecological model of health. And so this sort of is a visualization of what I was just talking about, the idea that an individual's knowledge, attitudes, and skills are only one piece of what contributes to a person's health. You know, a person's genetic code, that's within the individual, that may affect their health as well. But there are larger factors at work that can interplay with those individual factors to change a person's health. So the individual is situated within an interpersonal context. An individual has friends, they have family, they have colleagues, and all of those people can affect an individual's health as well. And those interpersonal connections are situated within an organizational context. Today, when I talk about organizational, I'm going to be talking specifically about hospitals or health centers or clinics. But there are a bunch of things that count as organizations. A university is an organization, you know, so that environment and the ethos of these organizations can impact interpersonal relationships and can impact individual health. And that organization that can impact an individual's health is situated within a community. Shared cultural values and norms will affect how an organization is operated, which can affect those interpersonal relationships, which can affect an individual, right? So this is nested all the way down. And so at the outermost level, we have public policy. These are laws, these are regulations, court cases and decisions that can affect everything all the way down. But what's really interesting about the social ecological model is that it's bidirectional, right? So a community influences the policies in their polity. An organization can affect their community. People can affect their organizations. And so this bidirectional social ecological model is just sort of a way of conceptualizing the way that health is deeply interconnected across all of these layers. And so when we're thinking about health advocacy, I'm going to go back to another poll everywhere if I can make this happen. We've got a new question, which is where in this model does advocacy happen? So is advocacy at the policy level, the community level, the organizational level, or this interpersonal and individual level? And so I'm seeing some responses coming in. I'm not sure of the numbers here, but it looks like most people say all of the above, which good. That is correct. That is the correct answer. I think often people think of advocacy as only happening at the public policy level, that, you know, to do advocacy, you go to Congress and you tell them what for, and then that's how you advocate. But that's a misconception, as 100% of you have correctly identified. Advocacy can happen at any and all of these levels, sometimes more than one at the same time. So going back to PowerPoint, oh my gosh, I'm so glad this is working. I'm going to talk a little bit about that outermost level, that policy level, just to give you the policy context in which all of these stories that I'm going to tell you take place. So immigrant health is deeply impacted by many public policies. I'm going to talk about three, which have been passed over the course of the last 30 or 40 years. So the first is the Emergency Medical Treatment and Active Labor Act, which was passed by Congress in 1986. And what this law did was it made it illegal for hospital emergency departments to turn away people who present in an emergent condition or in active labor, so people who are giving birth. So any hospital that accepts Medicare, which is essentially any hospital, if someone shows up and they're in an emergency situation, that hospital is legally required to stabilize that person, to assess and stabilize them. And so if it's an ongoing emergency, that might mean admitting them. And what's important to know is that this is an unfunded mandate. So the government says you cannot turn people away. You have to provide this care if someone's in an emergency situation. But then the government doesn't actually offer all that much money to pay hospitals back for this care, which makes this sort of a contentious point for a lot of hospitals, that if people show up, they have to treat them. And often you'll have people who otherwise don't have health care showing up to emergency rooms for care that could have been handled maybe in an outpatient setting. because they won't be turned away. So we've sort of created perverse incentives here with this policy. And so turning to the second one, this is a long name, the Personal Responsibility and Work Opportunity Reconciliation Act of 1996, sometimes called in shorthand the Welfare Reform Act, made a huge change to what federal health insurance immigrants in the United States could access. So up until this point, there weren't super strict laws about who could or couldn't get coverage for their health. In 1996, with welfare reform, it became illegal to use federal money to provide health insurance to unqualified immigrants. And I put that in quotes because it's not the easiest category to wrap your head around. So I'm going to give you a little bit of context on the next slide for who counts as an unqualified immigrant. But for now, one group that counts as unqualified, perhaps unsurprisingly, are undocumented immigrants. So if you're in this country without a green card or without a valid visa, you are not eligible for federal health insurance. So that's Medicare, Medicaid, CHIP, things like that, not available to undocumented immigrants. And then the third policy is the Affordable Care Act, or the ACA, which was passed in 2010 by the Obama administration. And so the Affordable Care Act made healthcare more widely available to more people than any previous act of Congress. But it intentionally excluded undocumented immigrants. So the ACA created marketplaces where many low-income Americans could access subsidized healthcare plans, but undocumented immigrants are not able to access those plans, and they do not get subsidies. So for like a maybe information overload, but a more detailed view of what I just said. Green card holders, so legal permanent residents, people who have applied for and received legal permanent residency status, are eligible for those marketplace subsidies under the ACA. But for Medicaid and CHIP, the Welfare Reform Act of 1996 made it so that those people, those green card holders who have been in the state for under 5 years, are not eligible for Medicaid and CHIP. Although they leave it up to states, so they can't receive federal funding, they can receive state funding. So if New York on its own decided to cover this population, so immigrants who had been in the country for less than 5 years who are here legally, they could, but they were not eligible for federal funding. And then this middle group here, we have refugees, asylees, and humanitarian immigrants. So this is someone who has received the political status of a refugee or an asylee. So an asylum seeker or a refugee is someone who has been forced from their home and then their home country, resettled in another country. And their status as someone who is forced out for reasons of persecution, that's assigned by the international community. So you have to have recognized refugee or asylum seeker, asylee status. But if you fall into that category, you are eligible for all three of these programs. So that 5-year ban doesn't apply. And when I say humanitarian immigrants who aren't refugees or asylees, that includes victims of trafficking and a few other smaller groups. And yet, despite the fact that they're eligible for all three of these programs, refugees, asylees, and other humanitarian immigrants still face a lot of health disparities and trouble accessing care. And we're going to talk about a little around that in the second story that I'm going to tell you today. And then I think, most clear on this chart is that undocumented immigrants are not eligible for any of these programs. And so states can, under welfare reform, cover Medicaid and CHIP for this population. To date, no states do, except for pregnant women and some children are eligible in some states. And in California, that definition of children goes up to age 26, but no other state covers adults who are undocumented. And so I know that's a lot of information that I just threw at you. That's sort of that outer ring of the social ecological model, the policies that create the context in which these three stories I'm about to tell you are situated. And I'm happy to take more questions on this because I know it was a lot of information at the end of the talk. But I'm going to turn to these stories now. So the first story I want to tell is about Dr. Lily Cervantes, who you see here. Dr. Cervantes is an internal medicine doc in Colorado, and her story happens at this outermost level of the social ecological model. So she has done public policy advocacy, and I would like to tell you about it. So her story begins about 10 years ago when she encountered the woman you see here in this picture. Her name is Hilda, and those are her two sons. Hilda is an undocumented immigrant. In this picture, she's a couple years into a diagnosis of end-stage renal disease, which is also known as kidney failure. Now, if you think back to those policies I talked about, Colorado, not a state where undocumented immigrants have access to federal health insurance. So when you have kidney failure, you need dialysis to survive. That is the only way that you can live. And so in states like Colorado, where undocumented immigrants can't access health insurance, the only way to get healthcare, to get dialysis, is to go to an emergency room. If you think about EMTALA, you could show up to an emergency room if you were in crisis, if your kidney failure were really bad, and you would be dialyzed on an emergent basis. So you could receive dialysis in the ED. And in Colorado, the way that this worked is that you would be admitted overnight and then released in the morning. And so, unfortunately, emergency dialysis is a really bad way to provide dialysis. This is an image from a graphic medicine piece about this same issue. You can see an image of a sick man in a hospital bed, and the caption says, "Without regular dialysis, undocumented patients with kidney failure face death almost weekly, waiting until shortness of breath, vomiting, or fluid buildup forces them to the hospital where they can receive emergency dialysis." And so in Dr. Cervantes Hospital, Hilda would show up to the ED once a week for this emergency dialysis, often in crisis, incredibly sick. Sometimes her sons, who were pictured in that first image, would be the ones who had to call for emergency services for their mother because they would have to wait until her kidney failure were so bad that she would be admitted. And then 6 days later, this process would repeat because it takes about 6 days to reach, crisis in kidney failure. And for Dr. Cervantes and many of her colleagues, witnessing this every week, building relationships with undocumented immigrants coming to their hospital, they really got a sense of how unfair, how unjust this policy was. And they saw the harms that forcing people to seek dialysis in emergency rooms was doing. It's an incredibly harmful policy. And you can see here a distribution of how different states do or don't provide access to dialysis for undocumented immigrants. Colorado here is in green because this map is from 2019, after Dr. Cervantes' advocacy, which I'm about to tell you about, was successful. And actually, a few more states have joined green since this image was created in 2019. In fact, I think about 9 more states followed Colorado's lead in changing their Medicaid policy to cover undocumented immigrants in need of scheduled dialysis. So just some quick nerd numbers for you here. You can see the difference in mortality rates, so the rate at which people die from kidney failure based on whether they receive standard or emergency hemodialysis. It is probably not surprising to you that people who are waiting 6 days between treatment have a much higher risk of death. And this was true for all patients and also for Hispanic patients, which it's broken out by. And you can see, in this yellow line, people who receive standard dialysis 3 times a week in an outpatient setting, their risk of death is pretty stable, right? You can live for a long time on scheduled dialysis. But if you are waiting until you almost die every 6 days, your risk of death is significantly higher. And so seeing these numbers and seeing these patients and hearing their stories and getting to know their families was incredibly distressing to Dr. Cervantes and obviously to the patients and their families. And so she undertook some policy advocacy. And so the first thing she did was step away from her clinical job. She still worked in a clinic, but she took time to do research instead because she knew, and this is one of my key lessons today, that stories are some of the most powerful advocacy tools in your toolkit. So she collected the stories of the illness experience of undocumented immigrants with kidney failure. So she did qualitative research, she did interviews with patients and their families who were experiencing this emergency dialysis. And this is a quote here from the paper with the citation listed here of an immigrant telling Dr. Cervantes about near-death experiences. This person said, "I've had people pushing on me right here in my chest. I think it's happened 3 or 4 times, but I don't remember much except that my chest hurt a lot afterwards and my family thought I was dead." So this patient was receiving CPR, almost dying several times because they had to wait between dialysis sessions. And these stories and the stories of the families were particularly powerful when it came to persuading people that this policy was morally wrong. Dr. Cervantes also did research, did interviews with clinicians who were treating these undocumented patients. So you see here a quote from a clinician. "You see patients that are awake and alert and talking, and then they come in a week later and they're basically in cardiac arrest and they die. That has been a really tough thing to experience. People you know by name." And so, again, collecting these stories and bringing them to people in positions of power was an incredibly important piece of Dr. Cervantes' advocacy. Another thing she did, aside from collecting those interviews, was measure the money, right? So I'm an ethicist. I find it really distasteful to have to make an argument based on money for people to do the right thing. But unfortunately, that's the world we live in. Often there are decision makers who are only going to respond to arguments based in, practical things like money and health outcomes. And so Dr. Cervantes, knowing that her hospital was making a ton of money by admitting patients overnight and billing Medicaid, emergency Medicaid, for those services, she was concerned that the hospital wasn't going to be willing to help her in her pursuit of changing this policy. So they collected the data. They showed that patients who experience scheduled dialysis actually save about $6,000 per person per month over the cost of doing this emergency dialysis, because emergency rooms are very expensive places to administer care. And so with the stories in her pocket, with the data in her pocket, Dr. Cervantes met with Colorado's state Medicaid administrator and built a coalition that involved not just other doctors, but the patients. When she tells the story of this work, she talks about a WhatsApp group that she created in partnership with patients who were undocumented, who were in kidney failure, where every time they went to tell this story, when they went to meet with the Medicaid director, when they went to meet with policymakers, they would also reach out to the press. And the press always wanted to talk to people who were experiencing this, who had those stories that she had been collecting. And this WhatsApp group, undocumented patients who are actually, really at risk for telling their story publicly, could not wait to tell their story publicly. They, in this coalition that they had built, did outreach. They went to the press, they told their story publicly. And this sort of cumulative effect of collecting these stories, collecting this data, building this coalition resulted in that change of policy that I showed you on that map slide, where Colorado now has coverage for scheduled outpatient dialysis for undocumented immigrants. And so in Lily's story, I think there are a number of aspects of this definition of health advocacy that are reflected. It's action by a clinician. Lily's a doctor, but also she worked with a bunch of other stakeholders to make this happen. And she made the political changes, right? They actually changed the literal policy in order to ameliorate suffering and threats to human health and well-being that she had identified through her professional work and expertise by seeing these patients in, day out in her clinic. Okay, so that was a story at that outermost ring, at the public policy level. But now I'm going to talk about a story a little bit closer to home. Some of you may know Dr. Andy Shaw. She's a pediatrician here at Upstate who did her training here at Upstate, and she's deeply embedded in the community here. Dr. Shaw works as a pediatrician with resettled refugees living here in Syracuse. And over the last year, I'm going to talk about one project in particular, although she's done a lot of work with this community that could be called advocacy. But over the past year, She's been involved in a number of projects related to resettled refugees and COVID. And so I situate this story, Dr. Shaw's story, in the community level and also the interpersonal level of the social ecological model of health. So if you are a resettled refugee living in Syracuse, New York, there are a couple of resettlement agencies where you might get services. And one of those is called Catholic Charities, and it's based at the Northside CYO, which is pictured here. And Dr. Shaw has worked closely with the Northside CYO for many years. And about a year ago, when it became clear that COVID was about to wreak havoc on this community, Dr. Shaw got together with CYO to see what they could do to help alleviate the strain that this disease was going to put on the refugee community. This is not Dr. Shaw's work, this is research by another group, but it shows the impacts of COVID-19 on resettled refugees in particular. So there are 6 different categories at which they identified threats to health specific to resettled refugees. One of the big ones was the suspension of resettlement and related services. So in a lot of communities, this isn't specific to Syracuse, resettlement was stopped or extremely slowed. So refugees who are living in other countries, in refugee camps or other nations where they have refugees integrated into the community, under normal circumstances, those people would be flown to the United States if this is where they've been identified for resettlement and reunited potentially with family members that they already have here. But because of COVID, a lot of that slowed. And so reunification and resettlement was basically brought to a halt by COVID. Another major impact on refugees, and not just refugees, this is across the board, but specific to the refugee community, was economic hardship. Many refugees working in the United States are working in essential worker jobs, but many others are working, they're low-income groups, and they're working in jobs that are potentially at risk from COVID. So refugees experience disproportionate job loss from COVID, but they also have difficulty accessing relief. So when the federal government says we're going to give $600 to every family, refugees don't always necessarily know how to navigate those systems to get that money. And so even if they were eligible for relief, they had a hard time accessing it. And sort of the flip side of that, they're also significantly more vulnerable to COVID because in refugee neighborhoods, many of them experience overcrowded living conditions. Many are working in high-risk occupations. And so that vulnerability is increased, it's heightened in refugee communities. This one I think is particularly heartbreaking, but mental illness exacerbations are really common in the resettled refugee communities, both because there are higher mental health needs. In order to be identified as a refugee, often you've experienced really extreme persecution, sometimes violence. And so your baseline need for mental health services is higher and your ability to access it might be lower. But also many refugees who are coming from refugee camps are used to sort of, or were used to in those settings, isolation or cramped living conditions, which were sort of exacerbated by being required to stay at home all the time. These memories of forced isolation and hiding are often exacerbated. And so I'm not going to spend too much more time on this, but I just wanted to make the point. The resettled refugee community here in Syracuse experienced all of this. And Dr. Shaw was seeing it in her pediatric patients, this at the bottom, boredom and loss of daily structure and school closing, really affecting refugee children. And so she wanted to do the work to do the advocacy work with the community to try to alleviate some of these stressors. And so in partnership with a whole bunch of people, this is another theme that you'll see from across all of these stories, is coalition building and partnerships. Dr. Shaw developed sort of a 3-pronged advocacy project. The name of the project is there in the middle, that's its official name under which it seeks grant funding. But the goal of this project was threefold. One was to increase surveillance, just to make testing available to refugees who may not have the transportation or the knowledge to seek testing at, say, the fairgrounds or another local site where testing is being offered. So instead, Dr. Shaw and a vast coalition of other healthcare workers and the CYO staff created a testing site that continues to operate every Tuesday at CYO, offering oral swabs to any refugee family that shows up for testing. And they can receive an oral COVID swab and know their status. Another prong of this project was to work with health navigators who are employed by Catholic Charities at CYO. These are folks who reach out to the refugee community and convince them to come in for testing. And another important role of the health navigators is communicating about COVID. So teaching the refugees that they work with about, how you do social distancing, why you should wear a face mask, how to disinfect surfaces, and how to get those supplies because they might not necessarily have access to them. And these health navigators are folks who are from the community, who speak the language, who are from the same countries as these various refugee groups. So working with the health navigators was another huge part of this project. And then finally, she's been engaging community leaders in the resettled refugee community, meeting weekly to discuss community needs. So I'm going to show a little bit about that. So one thing happening at CYO is the distribution of supplies. And so you can see here disinfectant, dishwashing soap, sponges, things that folks need to just, early in COVID when we thought you had to disinfect every surface, still should, but making sure that people have access to supplies that they need to stay safe. You can see here a number of the health navigators that Dr. Shaw has been working with. Dr. Shaw is right there in the middle in the blue Upstate shirt, but around her you see folks who represent a number of different refugee communities here in Syracuse, who have been helping with the testing, who do the translation, who bring in refugees for testing and for health education. And so this album cover is what it looks like of local folks who have been working as part of this project. I find this group incredibly inspirational and the work that they do super important, just doing that outreach. And then finally, I mentioned the community leaders. So community-based participatory research, I'm not going to get too deep into what that means, but it's working with the community that you're doing research in order to identify needs and to identify solutions. And so Dr. Shaw has created this community stakeholder, community leader group that meets weekly or bi-weekly to discuss the needs in the various refugee communities here in Syracuse. So you can see, this is a screenshot of a Zoom call. Dr. Shaw's there in the middle. I'm actually right above her because I was on this call. But just meeting with these community stakeholders, meeting with community health navigators and refugee families and Catholic Charities, the CYO staff, other resettlement agencies. So again, Catholic Charities is not the only one here in Syracuse. There's also Interfaith Works represented in this call to talk about the needs of the community and to discuss potential solutions. So right now what that looks like is trying to meet with the leaders of the community, and these can be religious leaders, these can be people who work for a local refugee group that does sort of leadership stuff in the community, to identify vaccine concerns. So hesitancy in this community and in some communities within the wider refugee community is super high. People are concerned about the effects of the vaccine long-term. And so meeting with leaders to find out how do we communicate about this vaccine in a way that is both respectful of cultural difference while still effective at convincing people that the vaccine is safe has been a big part of this project as well. And so to return to that definition of health advocacy, again, we see action by a clinician. Dr. Shaw is a pediatrician, but there are other stakeholders, as with Dr. Cervantes, involved here too. And one of the major things that they're working to change are educational factors. There's a lot of misinformation and a lot of confusion around COVID and around the vaccine in this community. And so doing that outreach with health navigators has been huge for changing trust and changing health beliefs and health-seeking behaviors in order to address the broader concerns of COVID in the community. And so with that, I'm going to turn to my third story, which occurred at the organizational level. So I said earlier, this means hospitals or universities. I'm talking specifically about healthcare settings today. And the woman you see here is Dr. Altaf Sadi, who is a neurologist in Boston. And Dr. Sadi has, in her capacity as a neurologist, experienced concerns around her undocumented patients being afraid to seek care, being afraid to come to the clinic because, especially over the past 4 years, of increased immigration enforcement. And so those fears of increased immigration enforcement have a formal name. It's called the chilling effect. And so as anti-immigrant sentiment and anti-immigrant laws and anti-immigrant action were taken over the last 4 years by the Trump administration, a number of people came forward to say, this is really affecting people's willingness to get necessary medical care. And you can see some headlines here. The first is a New England Journal of Medicine article that was published pretty shortly after the 2016 election, saying the chilling effect, post-election healthcare use by undocumented and mixed status families. And these two authors, Kathleen Page and Sarah Polk, who work with undocumented immigrants in Baltimore, argued that they were seeing considerably fewer patients showing up for visits in the wake of the 2016 election. A New York Times headline, ICE detained man who was driving his pregnant wife to a hospital. You know, if immigration enforcement is going to be occurring in healthcare settings and these stories are going to get wide coverage like in the New York Times, it's not surprising that people are afraid to seek care. And so following through the coverage cracks, how documentation status minimizes immigrants' access to healthcare. This is a different aspect of the chilling effect. You know, if you think back to that patchwork of eligibility for health insurance that I showed earlier, those coverage cracks also affect people's willingness to seek care. If they don't think that they're eligible for healthcare, they're not going to go for it. And so this is particularly true in mixed status families where you have undocumented parents, but maybe citizen children because they were born in the US. Those parents may not know that their children are eligible for health insurance. And so that's another aspect of the chilling effect where people won't seek care. And then another is just sort of sensationalist headline about immigration enforcement happening in a healthcare setting. 10-year-old girl is detained by Border Patrol after emergency surgery. And so these sorts of stories were really common, especially in the early days of the Trump administration, but they continue today. And so Dr. Sadi, seeing this in her own clinic, made a case in JAMA for sanctuary hospitals. And you're probably all familiar with the concept of a sanctuary city, a city where local law enforcement doesn't work with federal law enforcement around immigration cases. So if a sanctuary city detains arrests an undocumented immigrant, they won't hold them for federal immigration enforcement. They will process them normally and release them without cooperating with ICE or with CBP. And so Dr. Sadi made the argument that we should be doing similar things in hospitals and in healthcare settings, and she called this a sanctuary hospital. And so although she made this argument, she wasn't totally sure what evidence-based practices hospitals should be implementing in order to safely create sanctuary clinics or sanctuary hospitals. And so, like Dr. Cervantes, she took some time away from her clinical job to do research. She created an organization called Doctors for Immigrants, and through a multi-state study that I'm going to talk about in a second, she learned what practices sanctuary clinics could implement to protect their undocumented patients, and then created a toolkit that any organization or institution can use to implement similar policies in their own practice.
Dr. Fabi, just giving you a 5-minute warning.
Thank you. Okay, so she did interviews with healthcare facilities across 5 states, including 13 that are federally qualified health centers, to learn about what practices they were implementing in order to protect their undocumented patients. And so this toolkit that she created was derived from those interviews. So this is just an example of one of the policies that the hospital she spoke with told her about. One is to implement a policy that limits cooperation with immigration enforcement. So if ICE or if CBP shows up to your hospital setting, here are the legal ways that a hospital cannot cooperate with them. And so she produced in this toolkit some sample policies that hospitals can take wholesale and implement in their own practice in order to train their staff how to respond if immigration enforcement shows up in their clinic. It also includes examples of search warrants or immigration subpoenas so that hospital staff know what they look like and can know, oh, this is not a valid warrant, or this is not a valid subpoena. And so that's also available in her toolkit. She also produced a series of videos, which are available at that website, doctorsforimmigrants.org, that show what institutions and patients and providers can do to protect undocumented patients. And so in the interest of time, although that story has a lot more detail to it, I'm gonna rush forward and just say, again, this is a clear example of health advocacy. Dr. Sadi took action to promote social and educational changes to protect undocumented patients. And so in my last couple of minutes, I'm gonna turn to what you can do. And so a few common threads across all three of these stories. The first is community, finding partners. None of you are expected to reinvent the wheel or to create an advocacy project out of thin air. There are almost certainly already people, organizations, and groups working in your communities on similar issues. So identifying those partners, asking them what problems they face, and then offering your help as a person who has health expertise is incredibly powerful. Another common thread across all three of these was doing research. So Dr. Cervantes did her qualitative and quantitative research. Dr. Shaw is doing her community-based participatory research, and Dr. Sadi did qualitative and quantitative research with health centers to find out what policies they were using and whether they worked. And then finally, communication. So once you've got that data in hand, once you've got your partnerships, identify the decision makers who can actually affect change. So that could be state lawmakers or state Medicaid directors, that could be hospital administrators, that could be community organizations like Catholic Charities, and then tell your story. So go to the press, tell them what you're doing, go to social media, say what you have found and what you are working to change. And all three of these threads across all three of these stories are the tools of really successful health advocacy. And so in terms of actual opt-ins that folks here today could take, depending on which one of these stories inspires you the most, these are possible advocacy routes that you could take today. So look up the dialysis policy in your state, or if you're in a state like New York, identify the immigrant eligibility criteria. Find a community organization you care about, or research your institution's policies for undocumented immigrants, and then follow the lead of these incredible women I talked about today. I had one more poll everywhere that was just asking which of these stories speaks to you. See if I can switch to it, and we can sort of say which of these seems like the right one for you. But on that note, I am out of time, but I would love to take questions about any of these stories or any of the information I presented today.
Thank you so much, Dr. Fabi. Now I'll let Anjali, our chat monitor, just read out a few questions from the chat. Also, feel free to use the reactions button at the bottom if you would like to raise your hand. You'll be allowed to unmute yourself and you can ask Dr. Fabi a question.
Thank you so much for that talk. We seem to have a lot of great questions. The first one I'll start with is, could one independent hospital change their rules regarding Medicaid coverage for something like dialysis, or does the change have to be made on the state level?
Yeah, so in terms of Medicaid coverage, it's a state policy. So to get that state funding and the federal reimbursement, that would have to happen at the state level. A hospital could decide to offer that, using their own money. It's expensive upfront, but as the numbers show, it saves money over the long term. So a hospital would have to decide to make that investment, but they wouldn't be able to change Medicaid policy on their own, unfortunately. But that's a good question.
Thank you. And then the next question is, one thing Biden's administration has mentioned is opening the public insurance marketplace to undocumented immigrants without the federal assistance. how do you see this impacting immigrant access to health? And they also said, thank you for the talk.
Thank you. That's an excellent question, and one that has been thought about in states. So in 2016, before the election, so in the waning days of the Obama administration, California did just that. They passed a law that would allow undocumented immigrants to buy insurance on the exchanges, but they wouldn't have the same subsidies. And so unfortunately, in the early days of the Trump administration, California actually withdrew that policy because they were afraid that the Trump administration would use information about people enrolled in those plans to target and identify undocumented families. But one of the reasons why California wanted to implement this policy, even though it wouldn't have included subsidies, was because of the impact it would have on mixed status families. So if you have an undocumented parent, but a citizen child, you have that chilling effect I mentioned where people might not know that their child is eligible for healthcare. And California felt that if the parent and the child could both access care through the same portal, through the same marketplace, because in California, the marketplace also included the Medicaid plans, which is also the case in New York. They thought that that would reduce that chilling effect, that it would be more likely that people would be able to get coverage for their citizen children if they were able to get coverage for themselves in the same place, because it streamlined the process. So while it may not actually make a financial difference, having those subsidies is huge. It might make a difference in terms of mixed status enrollment. But great question. And the the ethicist in me just wants to say they should also be eligible for subsidies, right? I don't think it's the right policy, but I think it's a step in the right direction.
Another question we had is, are you aware of any agencies that assist with medical bills for people who are undocumented? We often see delay in medical care due to past bills and not wanting future bills. Medical bills can be particularly traumatic and concerning for undocumented people.
Yeah, that's a good question. I'm not aware of any specific agencies. I'm sure that there are community groups and mutual aid groups that try to address those things, but it's a little bit beyond my knowledge, unfortunately. But that's a great point, and I think that is a real problem.
Okay, thank you so much, everybody, for joining us. Unfortunately, that's all the time we have for our questions. But Dr. Fabi, if you're comfortable, I can definitely get some contact information out to everybody who attended the presentation. And if you have any more questions for Dr. Fabi, I'm sure that she would be more than happy to answer them. Thank you, everybody, so much for coming again. Thank you so much, Dr. Fabi, for joining us. And we look forward to seeing you soon.
Thanks, Isabel, and thanks, Anjali, for your help today. And thanks for the invitation to speak. I'm just really honored to be included.
Thank you. All right. Bye, everyone. See you to your next session.